just ready to go to work.
All right, so the first thing I need is a motion to adopt the minutes from the last meeting. Do I have a second? Senator Cooper, all in favor? Any opposed? The minutes pass. All right, the first thing on our agenda is a discussion of the hybrid healthcare model. So Director Gillespie, if you and your team could come up to the chairs, we'll turn it over to you. John, come on up too. And if each of you would introduce yourselves and your positions for the record, you'll have the floor.
Cindy Gillespie, Director of DHS.
Dennis Smith, Special Advisor to DHS.
Kelly Link, Legislative Intergovernmental Affairs at Department of Human Services.
John Stephen, the Stephen Group, representing the task force.
Thank you. We appreciate the opportunity to come today and provide, as you said, a look at the concept that's been developed. Just to provide a bit of background before I turn it over to Dennis Smith to talk this concept through, we have been working for the last few weeks to see whether or not an idea that exists in several other states of having provider-led organizations that work in a capitated type structure could in fact be a hybrid model to use here in Arkansas. This has been effective in a number of other states. Like anything else, if we do something like this in Arkansas, it will be our own unique version. It will not be a replication of something that went before. But we had been having conversations for a while as to whether or not something like this might be the appropriate way to move forward in Arkansas versus with a straight managed care or a fee-for-service construct in order to achieve the savings. I think we now have the governor's blessing to take this concept to the next phase of design and provide him a report by the end of November as to whether or not this hybrid model could in fact both achieve the savings as well as the quality and patient care that we all want to see in the behavioral health and DD structures. At DHS, we've designated Dennis Smith to lead the effort. Dennis is going to work closely with the provider community, others in the health industry, and with the Stevens Group. We appreciate the task force allowing the Stevens Group to work with us over the next few weeks. It's going to be quite a work effort to this quickly try to take a concept to design. However, it builds, we believe, well on what is already here in Arkansas. It builds on the foundation of work you've done over the years. And so we think it's actually a very viable concept, and quite honestly, we're very excited about it. If we can design something that achieves the savings and the patient care and the quality, and is something that we design together with the provider community so that we all move forward together to do this, we think that is, in fact, very much the best option for Arkansas. And so we go into this design effort at DHS really excited and enthusiastic and wanting to work closely with the provider community to make this a reality. As Dennis gives you an overview of what the concept is and the work plan and schedule, please remember it is a concept at this point. So there is a lot of work to be done to figure out how this concept goes from concept to design. But we thought it would be best to come here and just let everyone understand the basic concept so that as we go through the next few weeks, we can do it with a great deal of, hopefully, transparency and cooperative relationship.
Thank you so much. It's been great pleasure to be here with you this morning. We've
Excuse
got-
me, before you get started, I've got one question, and I'm guessing it's for Director Gillespie. So Senator Chesterfield, you're recognized.
Thank you, Mr. Chair, and good morning, Director Gillespie. I guess I'm somewhat taken aback because just a couple of weeks ago, you pleaded that you didn't know anything about this when we met in the basement of the cafeteria. Or did I misunderstand? That you were not, that DHS was not involved in these talks, that they had evolved from some other place? Was I mistaken in that concept?
Yes, ma'am.
So
But
you've
I
been
was-
involved in this from the beginning?
We have been involved, I've been involved in this from the beginning, yes, ma'am. And that is what I conveyed that morning at breakfast. If I somehow said something that made you think I was not involved from the beginning, I
You certainly
truly
did.
apologize.
Well, you
But-
certainly did. I was under the impression that this was being driven by private providers. When I talked with Kelly about it, Kelly said he didn't know anything about it, or am I suffering from
I
some
think
form
you-
of forgetfulness?
You may be talking about a meeting, an individual meeting.
So
But
you've
I-
been aware of this concept all along?
I brought this concept, this is what I thought I relayed to y'all that morning. I brought this concept to a group of providers and asked if they would be willing to fund a consultant to help us think through whether or not this concept would work. And that's what went on in a very aggressive period, with them understanding that if this was a viable concept, this concept would therefore be something that we would work with the entire provider and healthcare community to try to take to the next level of design, and that it would not belong to any one group.
Well, one of
And
the
that
things that
work
was
group-
of concern in the meeting, and I think Representative Gray was there, Senator Irving, all of them were very much concerned about who was being left out of the conversation. So perhaps I need to direct my question to Mr. Link. Mr. Link, did I misunderstand? Or did you say you knew nothing about the meetings?
Nothing about the meetings, yes, ma'am. We did not know when they're happening, did not know who's being, because we're not the ones inviting people to the table. It's the providers. That's why it's a provider-led organization.
So you didn't know anything about the meetings?
The meetings, no, ma'am. We do not know, I didn't know anything about the
You may
meetings.
not, there was
What
a
was
meeting.
going on, yes, but
Yes,
we don't know.
there was this one meeting that y'all were asking about that we did not know had been called.
I wasn't asking
But
about
the
a
other
particular
meetings,
meeting.
the
Cindy.
other meetings, ma'am, I was at those, and a number of my people were at those. So I have not tried to, hide our involvement with this from the beginning.
So my remarks at the meeting about the lack of transparency was just for the heck of it, because everybody was at the table that needed to be at the table. And one of the major,
Not everyone was at the table that needed to be at the table. That is a different thing. This was early concept to see whether or not it was valid, ma'am. And it finally became clear that this could be a viable concept, at which point we said, now everyone who needs to be involved needs to get to the table. And in fact, one of the things that I did last week was to put out a note to the providers that have been involved and said, going forward, please ask all who have been involved who else should be involved. Please ask them to bring them to the table. If we hear of anyone else who wants to be involved, we're going to refer them over. And please bring them to the table. We don't want to design this without everyone at the table that needs to be at the table, that is going to actually be implementing this. It won't work if we do it that way.
So I got one message from Kelly. I'm getting another message from you, that you knew about this all along. And so when I've listened to all of you had to say, and I'm not going to beat it to death, Mr. Chairman, to move on, but when I asked Kelly, I said, Kelly, what is this? I'm hearing about meetings that are taking place where some of the providers feel they've been excluded. Kelly called me and said, I don't know anything about it, and then sent me a text message saying, we'll have a meeting in the cafeteria. Now, that was my understanding, and in that meeting, I told you transparency was important. I said, Arkansas is just small enough for you to think you're doing something, and large enough for you to think you're doing something without anybody knowing, and large and small enough for everybody to know. So we have a failure to communicate here, because I was under the impression, and I don't think my impression was wrong, Perhaps the facts were wrong, but the impression I got clearly was that DHS was not a part of these discussions. Now I'm hearing you are a part of it. We're talking about bringing in somebody. This man was there, which made me think that that couldn't be true because he wouldn't be here if he hadn't been a part of it. The gentleman to your right.
Senator,
That's it for me, Mr. Chair. I'm just frustrated with the whole process. I'm sitting here thinking that providers have been excluded from the conversation. I was led to believe that DHS was not a part of these conversations, and now we're moving ahead full-blown with something. Thank you.
I've got a couple more questions. So if it's going to be about, since I'd like to hear what this thing is, so I've got two more questions, two more people on here. I'm happy to go to questions, but if it's going to be more, let's let everybody know what we're talking about, and then we can go back to who heard it first, but that way at least everyone in the room will know what it is we're talking about. So the other questions, if that's what they are, can we pass on them? If that's not what they are, let's go to the questions. Senator Cooper, you're recognized for a question. Okay, well, we'll come back to that, and we'll fully vet that out, but let's let everybody know what it is we're talking about, and then we can come back and talk about who got it first. So Senator Raper, you're recognized for a question.
Thank you, Mr. Chairman. Any of you that would care to answer, who regulates this hybrid entity?
Go ahead.
It will be regulated both by DHS and the insurance commissioner.
Okay.
And they will have to follow the federal rules dealing with Medicaid managed care.
I'll save the rest of my questions till later, but that sets me up. Thank you.
Excellent. You can continue now, please.
Thank you so much. I'll try to move through just a handful of slides very quickly. As Director Gillespie indicated, this is a concept in motion. We are building the car as we started out with a concept, but obviously there are many, many parts that have to be discussed and put together. But overall, if I may start on the first slide, that this is really what I call organized care in a manner that individuals who are high cost, high risk, who will benefit greatly from an organized approach to coordinating their care. And these are limited to high-cost individuals, those with behavioral health needs and developmental disability populations that will go through an independent assessment process and be identified as in Tier 1 or, Tier 2 or Tier 3, which indicates that they need a high level of intensive services to meet their needs. It builds on what we already have here in Arkansas, the person-centered medical homes. Again, this is an approach that does not try to replace or disrupt the fee-for-service system that is already here in Arkansas, that the tradition and the history of fee-for-service would be continued. We are not disrupting this for the entire Medicaid population. We've got 1.1 million people on Medicaid right now. This is for a small group of high-cost individuals, so it's a very targeted approach and leaves everyone else alone. No one else is going to have changes in their service delivery model. It's also builds on proven models. A number of states already have what are called regional care coordinating organization. Oregon and Colorado are two in particular that have been very well known. But it is unique to Arkansas in that those models, and I want to hasten to say this, if you go and start looking at Oregon and Colorado, there are still big differences between what those states have done and what we are proposing here. Those models go to their entire Medicaid population. As I said, ours is very limited. Their models introduced a number of other payment reforms. We do not do those things. So again, I don't want to say, if you look at those states, this is what we're doing, because that is not the case. The idea, though, that there are regional coordinating care organizations that are given certain responsibilities and tasks for organizing and coordinating the care for those populations. The second slide, please. The principles that we have laid out and that we are following, first and foremost, that this be provider-led, that it's comprehensive, integrating the whole person care. So the small number of people who are involved, their entire care would be coordinated through the system, both in their waiver services and in their acute care needs, because in many respects, and it has become increasingly recognized, of integrating behavioral health services in with physical health services. You have an individual who has multiple complex medical decisions. Is it the individual's mental illness that is that is the root cause of how the individual is functioning today, or is it because the individual also has diabetes and his blood sugar is low? So again, this integrated approach that you're looking at the whole person. It would be designed to meet the 5-year savings target. And again, it's very clear that this model is would be built on attaining the same levels of savings that the task force has discussed and by the Stevens group. Reducing costs by managing the care, not just by money. And what I mean by that is often managed care organizations, large organizations, so much of that is about the risk and the financing side of that. All of those are very important. But it's the managing the care of these individuals to make sure they're getting the appropriate level of care, that there's not overutilization or underutilization. And in many respects, we would expect individuals to increase their use of primary care. We would expect an increase in greater adherence to the medications they're on, for example. Incentives to change utilization patterns. Again, I think that is one of the issues that other states have struggled with, and I believe the federal government has struggled with as well. They have taken a very marginal approach, and they are talking about, in many respects, those models do not allow enough of a reward to those providers for getting the care right. It is also designed to generate the premium tax as the non-federal share, so general revenue funds would not be would not increase, and in fact, a premium tax would draw down additional federal funds that could be used for a variety of different purposes in the Medicaid program. And will phase in the risk over time. This is not a model that everyone would be ready to jump into immediately and take full risk. So again, we envision this being phased in over a several-year period of time, and who accepts risk as well. Next slide, please. The administrative simplification of this, and again, many models have become extremely complex and are kind of missing the boat in my estimation of becoming overly complicated. We'll envision that it would be a single global payment that would be made that would cover both the benefits and the administrative costs and the care management costs all down the line. We don't see this as being, negotiating many different separate pieces. We want one global payment that we really would be focused on. Using a certification process, and what I mean by that is DHS, and to part of the Senator's question, we would define a certification process. What does it mean to be an RCCO, a RICO? What requirements have to be met to be identified as one, to be certified as one, versus a competitive process where, again, which would lengthen the period of time, in my estimation, if we went through a full-blown request for proposal process. We believe this is a much simpler, cleaner approach. And again, the departments, the two state agencies would exercise their respective roles. The regional coordinated care organizations really are the backbone of the model. These are locally, regionally based organizations, as I said, that truly will become accountable for the delivery of care, carrying out the individual care plans, coordinating care among individual providers, linked to provide access to specialty care, and a large portion, and a very important component of that, is to be able to share information and data about that individual. And as I mentioned, accepting risk over time. The WICOs then, in turn, and again, I think that the number of these will be relatively small, spread throughout the state. We hope and believe that it would become statewide. But the WICOs themselves then would choose their administrative agency to process claims and track performance measures and incentives, et cetera. Again, one of the common themes of all of these other models that I mentioned in other states is the accountability for demonstrating outcomes for individuals. Again, this is not just process, it is not just a reporting requirement, but there are actual performance requirements that would need to be met and would be linked then to financial gains for the organization and the individual members and the providers. The other portion of this are what are they calling APCOs, Arkansas Provider-Led Coordinating Care Organization. That organization, again, would be an umbrella organization, would have to meet criteria that is spelled out, and as I said, accountable to both DHS and insurance. The majority of the representation of an APCO would be owned by the providers themselves. And again, I think this is a critical point to this, to the tradition of Arkansas to understand that the providers themselves are going to be the majority owners of this organization, not some external group. We would spell out governance board representation that providers, beneficiaries, consumer advocates would all need to be represented on the board. And as I said, the APCO would then do the centralized administrative functions that you see in any organization. The work to date, as was previously mentioned, a small group of providers under the partnership began work somewhat with those of us at DHS, but also outside of DHS. They independently contracted with Health Management Associates, HMA. This is a nationally respected consulting group that they hired using their private dollars to finance those efforts to help develop the preliminary concept models and financing, again, to see whether or not this could potentially be, and I emphasize the word potentially, a financially viable solution. Again, at the end of the day, we all know that if it doesn't work financially, then there's going to be no interest in doing it. That group broadened their outreach to involve additional provider groups, including behavioral health and DD providers, is my understanding. Last Friday, I participated in a briefing that HMA provided to the Stevens Group to bring the Stevens Group up to date on what had been done as well. The last slide is what we see. Again, we understand there's a very short timeline to be able to move this towards the launching pad. Not that it would be launched, but move it towards that, of whether or not this model is viable and acceptable. Again, this is, as a provider-driven model, this is going to have to be acceptable to a broad group of providers, that they're going to want to be able to see that they have a stake in this. And to that effort, we've laid out a schedule to assess that viability. This week, we intend to draft an initial concept paper in itself, moving beyond these handful of PowerPoint slides to a detailed concept paper that will answer at least many of the questions that individuals would have about that, knowing full well that many more questions will be answered as we move through this. We will also begin the last week of October inviting individual provider groups to participate in working sessions and breaking those working sessions down into some manageable pieces. First, on the structure itself, to get people comfortable with RICOs, to get them comfortable with the roles that they played, on the definition of expectations. What does it mean to be responsible for the care coordination of individuals? Secondly, on quality and improvement in patient care. Again, these are intended to be very outcome-based performance measures, providing greater care in the community to avoid higher cost in inpatient hospitalization, for example. So how do we actually measure the performance in work sessions on governance and certification? Again, what does that mean? What are the requirements that would have to be met? And saving the most, no doubt, popular, but also thorniest question for last on risk and financial issues. We all know that if you start the discussion about money, you won't talk about anything else. So we're saving that one for last. Then the final week of November, submitting the final concept paper and recommendation and plan to the governor.
Representative Sullivan, you're recognized for a question.
Thank you, Mr. Chair. Back over here. I'm on the page, Regional Coordinated Care Organizations, and the last point, we'll choose administrative agencies to process. You know, as a small state, we have probably limited number of people in the state now who can do that. Could you give me some examples of who's operating in the state now that one might choose to do that?
I don't know that I could list all of them, but this is a function that any insurance company could carry out.
Okay.
Managed care companies do this as well. So
Okay, so it wouldn't necessarily have to be in state either, I assume.
that it doesn't necessarily have
Okay.
to be.
All right, thank you. Thank you, Mr. Chair.
Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. I guess my question would be, you know, when we presented Diamond Care back in December, how is this different from Diamond Care? Because this encompasses a lot of the same pieces. You are making this provider-led instead of ASO-led. Is that the only difference here, is putting the risk entirely on the providers?
I think there are a number of differences, one being that it is targeted to a very small population. It is not statewide. It is not for all populations. I think that, again, the concept that the regional care coordinating organizations themselves are really the lead. This is more of a bottom-up approach rather than a top-down approach that I viewed Diamond Care as being. And the matter of risk, I think Diamond Care had a number of other provisions in there on provider reimbursement, et cetera, that this would not have.
Okay, so when you say not all populations, could you please expand on that?
This is limited not only to individuals who have a diagnosis of severe and persistent mental illness, but they would fall into what we call Tier 2 and Tier 3. So these are the highest risk individuals, and the same on individuals with developmental disabilities.
Okay, so essentially, if you just took out those pieces out of Diamond Care, the DD and behavioral health pieces, it is what we presented, but it places the risk mostly on the providers, which we are already in I've gone from 8 physicians to 2 in Izard County right now. So when you place more risk on the providers,
Individual providers may not take any risk whatsoever.
so which ones are we looking at? Like, you mentioned UAMS, would they be considered provider-led?
An organization, and again, I think in starting the discussion, I don't want to get limited to individual providers or groups, because I can foresee a number of providers wanting to at least start the discussion as to whether they become regional care coordinating organizations. I think large hospital systems are a logical approach, but I don't see them limited to that at all. I think others would as well.
And you might want to elaborate on the risk being at the APCO level, because whether or not it flows to the other levels
Right.
is around the relationship between the other levels and then the various individual providers with the APCO.
Correct. Yeah, I
So
want to emphasize that again, the risk does not necessarily flow down to individual providers.
Okay, well, and it's the same thing. I'll be done, Mr. Chair, in just a moment. So if essentially the hospitals, they're the only ones that would, in my mind, be large enough to take on the kind of risk we're talking about here. But it's just like if I go buy a tank of gas and we add a 20-cent tax on it, the end user is going to be the one that ends up paying for it. If the hospitals take on the risk, someone has to bear that burden. It's going to end up being the providers, the ones who are actually on the ground floor providing the care. And when you start tampering with, you have that mix, that balance right now with providers between, income and care. When you overbalance that and the money is more important than the care, you've just undermined everything you're trying to do.
Well, if I may,
I'm
and
done,
again,
Chairs, thank you.
if I may, and I want to go back to emphasize the difference between managing risk and organizing care. Again, our intention and part of the concept itself is to build an incentive pool for providers to reward them for improving access to community-based care. As I said in my remarks, I see primary care, and this is borne out in other states' experience as well, utilization of primary care actually goes up. So those individual physicians and other community-based providers, they're the ones who actually will see increased business, and the savings come from avoiding trips to the emergency room, from avoiding hospital admissions, and shortening the length of stay. So it really is the community-based physician that has the potential to be rewarded for improving the care coordination.
But that's exactly what we proposed in Diamond Care, was to use a more patient-centered medical approach with the behavioral health and the DD population, but without the amount of risk. No matter what you say, it's going to trickle down. It's going to happen without that large amount of risk coming to the providers.
If I may, I think we only heard this Friday, so I'm just getting the first
It's
blush.
new to us, too.
But Representative Gray, I think you're absolutely correct. I'm still looking at it just first blush. You have a couple options we gave you. Managed fee-for-service, which was Diamond Care. Then you had mentioned Diamond Care, and then we talked about, well, Diamond Care needs to have some risk to meet additional savings. Then you have capitated full risk managed care, where one entity is taking all the risk. And it's somewhere in the middle. But you're right on the right. The questions you're asking are the right questions. The issue comes down to risk. What type of risk will the providers be sharing with the entity? But think of it like your administrative service organization entity in Diamond Care. Probably that entity taking on a lot more role and responsibility in organizing the care of the providers. But again, we're going to be working to try to figure out exactly what this all means, but with that in mind. I
And
think
just-
you're on the right track.
And just a final point, the reason you're seeing so much that looks like Diamond Care in it is because this is a hybrid. It is partly what was in Diamond Care and partly what is in managed care, and trying to merge the best of both. And hopefully, when we get into the next few weeks of design, try to avoid the worst of each, right? So that we find a way through. We don't have, it has to now be designed. And so we don't have all the answers. But that's the goal, to capture the best of both and not the worst of either, if we can.
Senator Cooper, you're recognized for a question.
Mr. Chair. Ms. Gillespie, do we have anything in this state called the Olmsted Plan?
The Olmsted, yes.
When's the last time it's been updated?
Hold on, I honestly don't know. So let me see if
Well,
someone on my team can answer that question for you.
okay, that's okay.
Director Cloud said it's been several years.
Okay.
But we'll get you a precise
I don't
information.
need the exact date. That tells me what I need to know. And to John Stephen, we've been at this for almost a year, and anybody that knows what the Olmsted ruling was knows that's the most important lawsuit that's ever come down the pike in this country concerning mental illness. Right?
Correct.
Okay.
It is also development disabilities, too.
Yeah. What really concerns me is I hear a lot of talk about regionalism. And that lawsuit was all about, and that decision was all about community basing. And I hear almost nothing about community basing. Now, in 2002, this state had a lawsuit concerning some mental illness cases. And there was a Terry versus Hill case in which this state lost. And Mr. Hill was a mentally ill patient and had been ordered by the court to receive mental illness treatment. And 6 months later, the court found out that he was still in jail and received none. That turned into a class action. And these cases were so severe that the court heard testimony about people eating their own flesh and drinking their own urine and eating their own feces. And just recently, you know, we've heard slides and we've seen testimony about other southern states and how other people are doing it so well. And 9 weeks ago, the state of Mississippi got sued by the DOJ over exactly the same thing. And the key in all of this is community basing, and I'm hearing none of that. And when I hear regionalism, it tells me that we're going in exactly the wrong direction. The DOJ quoted some financials concerning Mississippi, comparing the money that they were spending on institutionalization and the funding going in the wrong direction, and they were comparing $470 per patient per day on that versus $30 per patient per day in community basing. And I just wonder why that we're a year into this now, and I didn't hear a thing about these lawsuits until I started looking into it myself. I didn't hear it from any consultants. I didn't hear it from DHS. I didn't hear it from anybody else. I didn't find it out until I started looking into it myself. And what I'm getting is far different from what I'm hearing. And I'd like to hear some response to that, please.
I'll start and then ask the two of y'all to add into it. We 100% agree with you that what we need to be focused on here is growing our home and community-based services. And one of the very important reasons why we are both pursuing the rules changes on DD, the rules changes on behavioral health, and trying to combine them with something like this hybrid model is because if we don't build those home and community-based services, if we don't build out both the providers that are there, help them to grow, help us to have more services and quality services, we will find ourselves in the same place. And looking at Arkansas, what we have believed is that the work your task force has done to design savings, the way you've designed them allows us to actually grow the services and grow the community-based services. And that, I think, is a very, very, very important element of what's going on. As you look at, for example, the behavioral health rules transformations coming, while it puts limitations on intensive services, meaning it requires the independent assessment before, someone gets those services, what it does is it opens up community services. It opens up the ability for those services to be provided in a lot more settings so that it's much easier for folks to get those services, for doctors to prescribe them there in their own clinics if they want to. That beginning to grow out those services is hugely important. I apologize, we have not used those terms, and we have not really talked about it to the degree we should. But a big part of doing all of this is to be able to move to doing more with crisis teams, for example, that can go into areas and support when help is needing, looking at more crisis centers, looking at being able to do more in the communities and grow those home and community-based providers. As we talk to those providers, we talk to them about, if you're providing one type of service, could you provide that service to a different population? Could you grow what you're doing? What kind of supports could we provide to do that? When Dennis talks about these new RECOs, working regional care centers, it's about those regional centers really then working with the providers that are there in the community to grow them and receiving both the financial incentives from these premium tax monies and others to be able to help them grow their capability and the quality that flows on it. That is the cornerstone of what we have to do here. And we clearly are not communicating that, and it is really critical. It's also why we know that those particular providers, to the question that was being raised, we know that those providers are not the ones that are going to be bearing risk, right? We've got to grow those, and we need to make it to where others in the structure realize that and help us grow those, and it works within their financial model. Dennis and John, if y'all would like to add, please.
Also, if I may, Senator, and again, I'm new, we haven't had a chance to get to know each other, but after Olmsted, one of the most significant pieces of legislation and administrative action was increasing the use of home and community-based services. And I think if you look back at the time while I was at CMS, we have now crossed the point in which more services are delivered in the community rather than in institutional care. One of the most important initiatives offered to states was something called Money Follows the Person that we had passed in the Deficit Reduction Act of 2005. And that was one of the initiatives that I had championed. So we're very much on the same, we view this very much in the same way. Money Follows the Person helps provide additional funding to states to get people out of institutions, and that's where I've been coming from.
Well,
I'll add to that if I can.
Okay.
Senator Cooper, one of the things we're looking at this on your behalf. we represent the task force. So the one thing that we have said from you from the very beginning was this state needs to shift its reliance off of institutional care into community-based care. That was one of our very first recommendations. I think you've done a great job in really pushing a lot in the preliminary task force recommendations. You mentioned it. We mentioned Olmsted in our report. We continue to mention Homestead. We know it's an issue, but I will say, working with Senator Rapert and also Representative Hammer in the HDC committee, you know, you don't have the quality of care issues that other states have had that we saw in your institutions here. You take good care of your residents, and at least what we've seen. So I would be careful, you know, not to use Olmsted, though, and just wave up a white flag to the federal government. I do agree, and we're going to have in your final report for you to look at as recommendation completely a lot of home and community-based care suggestions, because the only way you can reach the savings, whether you refer to this as regional, community-based, it has to be just what you said. It has to be deinstitutionalized care in the community with good quality of care and quality of life. And so we've got to make sure that the capacity is there of the provider community, and you have to make sure they're paid well as well. There are some rates that we shared with you early on in our recommendations on home and community-based care at the very entry direct care level that also need to be looked at. So all of these issues are issues that we would bring independently when we're reviewing this on your behalf. So you raise a really good point.
Well, I'm not through raising it. There's another aspect to that. In 2011, there was a crisis unit at Jonesboro, and it was shut down. And so you'll maybe forgive me if I'm got a very high degree of skepticism. My red flag is running high. Because right now, what's happened, we've got no way of handling crisis at Jonesboro. And I talked to the sheriff up there just a few days ago, and he's transporting people as far away as Jonesboro to Texarkana. And they're not getting reimbursed for that. Craighead County is eating that. And that was all because we shut a facility down at Jonesboro, and now we're going through apparently the same thing with Mid-South, the 9/11. And I've been assured from a long time now that everything's okay. Well, everything's not okay. And so I'm skeptical. Thank you. Thank you, Mr. Chair.
Representative Murdoch, you're recognized for a question.
Thank you, Chairman. A couple things. Going back to the inception of this, because obviously, whenever we have these type gatherings and we find out at this last moment, then obviously it brings about lots of questions of transparency, trust, and other issues that we've suffered from. So please be patient with us as we try to get where we need to be to represent the people that we're charged to represent. Going back to the original table, as I call it, you know, so many times the considerations that Senator Cooper and others, Senator Chesterfield and others have mentioned are left out or not properly considered when the original table is not representative of everybody involved. There becomes a developed or a table that's to suit a certain purpose or meet a certain objective. To avoid that, the way you do it is you include everybody to the table, you hear all voices, you get all inputs, and then everyone feel a part of the process. When you don't do that, you get where we are now. We want to get away from that. I think this committee, I think the state of Arkansas, providers, everybody involved want to get away from this lack of this sneaky feeling, you know, almost kind of a thing. It's not necessary. Because it's going to come. At some point, it's coming to us, and we're going to have to deal with this. So at whatever role you're playing in this, from the director to a consultant to whatever you are, please press for integrity and transparency in this process so that we, through a tough process, can be at least cordial to one another. Because when you break down relationships and people feel like you're trying to do something to them, that affects the ability to get something done. And you feel thickness in the air like you feel now, because people don't have the confidence in the relationship and the person that they're looking at in the eye, that they're telling me the truth. That's a problem. Okay. Now, the table. I haven't heard anything about consumer advocacy groups being at the table when this all evolved. Providers, what providers were at the table? Where is your source of coming from, your sources that are advising you? Are the associations at the table where it's limited to just this many? See, there's so much that we don't know, and we're the ones that have that get these questions. So it's very important that all of that is addressed, and what it looks like, just so you'll know what it seems like, that we're going to a regional managed care type situation. That's what this kind of starts to look like, which I'm not against for, really I'm not even commenting outside of what it seems like is going on. Please help my unbelief.
Representative Murdoch, if I could address a little bit of some transparency, and then obviously when it gets technical, it goes to the left of me because they're all well advised on this. You have to have ingredients. We talk about. I think this legislature feels like we have a cake in the oven and it's baking, and we don't. We have the ingredients laying out on a bar that we're looking at putting into a mixing pan to start mixing it up to see what we get. If you look at this schedule over the next month, that's really just taking a concept and trying to figure out if it will work. By no means is this group here telling you this is what we're advising to move forward with. We're actually being transparent by being here right now. We're trying to tell you this is a concept that we have. This is the ingredients that we've set out on the bar to put into a mixing pan to start wicking it up before we even put it in the oven, before we even think about taking it out. So please understand, you're in the very infancy of this right now. This is transparency. There's not been a group of people invited to a table, especially not by DHS, to figure out what to do. That invitation went out via the governor's letter through Ms. Gillespie just last week, and that invitation is out to every provider. And we've advised this group, that this group that's looking into us, of this group of providers, if any provider calls you, please bring them to the table. So we hope that right now this is transparency. That's what we're trying to be. And so, yeah, we just have the ingredients on the table. We'd like to start mixing them, and that's why we're bringing them to you.
Well, and you chose to come down this street, so let's walk a little bit since you chose to come.
Sure.
Now,
We'll walk hand in hand.
obviously, Representative Link, there has been lots of sit-down, coordinating, talking, discussing, because there was a proposal prior to that last page of several things that are specific and has went from regional to all kinds of information here that I've had just a chance to peruse. So the transparency target we've missed. Now we can catch up and we can forgive and we can go forward. But we missed that because there are people in this room that not sitting up here with me that have not been a part of the process that will be affected by this process, be it providers, associations, consumer advocacy groups who represent people, and many of these people can't speak for themselves. So I think that we need to visit that a little differently, and when we say that we've been transparent, because there is some sausage being made, and it's obviously this here is a direction. There has been a direction chosen with some specificity that's in this report. So if that's been done, then what I suggest, or what I'm asking is, why wasn't it done in a different manner whereby we can all come here and just work out the kinks as we go forward with that last page table and have a kumbaya versus what we're getting now? Somebody has to be accountable for starting this thing off right.
And again, we've got to point a direction to bring it to you. If we just sat down here and said, hey, we're looking for a direction, that's what we've been doing for a year and a half. We've been looking for a direction. So we're coming here with an idea of a direction. We're coming here with an idea of ingredients that can get us a cake. And we're looking for you to look at these ingredients with us, help us mix it up, help us get providers to the table, and let's see if we can bake a cake in Arkansas that works for us. We don't know if this will work.
Representative Murdoch, we always knew, or I always knew, that if this was a viable concept, and I mean, like he said, a set of ingredients that could maybe come together to something, that as soon as we knew it might be viable, it would need to pull everybody to the table to see if people wanted to work to design it or not. And that's really where we are. Until it was an idea that might not work for Arkansas. It still may not, right? But an idea that you just had to put a little bit of looking into it to see, is it even a potentially viable pathway? It is. Then great. If folks are interested, providers are interested, can we all come to a table and see if we can design it and see if it would work? If it would, we would prefer to find this kind of a hybrid pathway with everybody wanting to go down that road together. I have always known if this was a viable way to proceed and it went all the way to design, it requires legislation. This is not something we could do. You're exactly right. This is something the legislature would have to do. The governor would have to decide he wanted to move forward, and then the legislature. So it is, as Kelly says, it is very early. It is a viable concept, but we worked with, we had to have some help, consulting help, to be able to look at the models in other states, figure out how those fit together, figure out what applies to us and what doesn't.
And that's what I want.
And that's what we've done, but always from the beginning going as quickly as we know this is viable, it must go public, and it must be something we see if folks want to come together with us to design. So I'm sorry, very, very, very apologetic that people feel left out. There hasn't been that much to this point, and all the details now are to come. If the concept, as people learn about the concept, if they say, no, you might think it's viable, DHS, but we don't, then it doesn't go forward. If they say, okay, it's viable, but we really get into it with providers to work through those details, and this is, to Dennis's point at the end of the day, these discussions over the next few weeks with the providers, who all, we hope, will come to the table, anybody that wants to be, that it's a business model discussion, right? It's a discussion both about business models, and then it's a discussion also about delivering care to patients, and it's a discussion around how do we grow those home and community-based services, and how do we ensure that even as we get our fiscal savings, DHS gets the certainty of those fiscal savings, and you all do, at the same time that the result is more care coordination and more services available all the way down and into the communities. It's going to be complicated. It's going to be very complex. And, you know, the process of working ourselves through this over the next 5 weeks, we're committed to. It's going to take a lot to do it, but we are very, very committed to it. If it could turn out to work, we would then spend December working with y'all to draft legislation for y'all to consider in the next session. If it doesn't work, then we won't all do that. But if it does, it's really going to end up being up to the legislature whether this happens, because the governor will accept my recommendation one way or another, and then if he wants to move forward, it's going to require legislation. We cannot do this by ourselves.
Okay, so in the evolution of that, I think since you've been here, you've taken this on and you've come up with this hybrid, or you've led this initiative that we have in front of us now. Now, Arkansas providers, associations, hospital associations, providers, all the people that, and consumer advocates as well, everyone that has to come together with you to make this from here forth is what you're telling me now, that you're going to get with them, because a lot of them obviously have not been a part of this yet, but now you're going to bring them in. So who did you trust to get you to where you are now? If you didn't use the Arkansas people that's going to be a part of this process, who's going to have to get okay for this to work for our Arkansas people, who have you been dependent on?
The primary people behind the substantive work on this is a company called Health Management Associates. Health Management Associates, HMA, is a national consulting firm largely made up of people who are former Medicaid and HHS secretaries, Medicaid directors, et cetera. A number of the people at HMA have been part of the design of risk-bearing, these are called risk-bearing provider organizations.
Excuse me, Director. Is HMA the group that applied for the contract that the Stevens Group got? Is that the same HMA?
I believe they were one of.
Is that the same one that bid?
It was PCG and somebody else. I don't know the name of they two came together. PCG and somebody else came together.
No, that was PCG and McKenna Long and Aldridge.
Right. You're
That was
talking
a
about
different
the
group.
contract that we awarded to Stevens
The
Group?
contract that we awarded
Yeah,
to
that was,
Stevens Group.
all right, you're right. McKenna and PCG was the one that did not get it. They
Yeah,
were
but I
the
thought maybe
finalists.
HMA was, that
Yeah,
came
there were 6
initially.
of them that came. Yeah, I don't remember the other 5.
I don't know if HMA was one of them or not.
Was the Stevens Group a part of this conversation prior to this last week? Were they a part of the sausage of this?
No, they were not part of the sausage of this.
So the
We
Stevens
briefed them
Group
all.
is who we hired as the consulting, and we paid them a nice,
Yeah,
they had a nice
they can't,
contract.
Representative Murdoch, they can't.
can't
They're
work
our
for us.
consultant.
So they could not-
They're our consultant.
No, but I'm saying you could not have asked for permission to consult them in this matter as you went forward, because they have the relationships, they've met with these providers, these associations, so there's a lot of the work of the matter that they've already developed relationships, if you will, broke down some of the barriers, know some of the players. So I'm just saying, for time's sake, because we're running up on a time crunch, then you could have consulted with the Stevens Group just to help in this matter. We could have made an arrangement to pay them if we needed to. We do that every day in situations that we want to do it. So wouldn't that have made a little sense from a uniformity even, and time?
The consulting group that's been involved has designed these types of organizations in other states.
But I'm talking about
So
Arkansas.
But Arkansas doesn't have this type of organization. So they have the experience of having actually established these and working with them. Doesn't mean that, very much we want the Stevens Group working with us. One of the very first calls we made as we realized this could look like a viable model was to the chairs of the task force to ask if the Stevens Group could be brought in for the next few months to try to take this to the next level of design. We want them working side by side with us on it, not coming in after to evaluate the work.
And maybe this is my last part, Chairman, and maybe I'm, missing something, but I just think when I look at the clock that we're on, and we'll get into a rush situation to do something, and then the people we represent we may not be able to do the best job if we're rushed. So I'm just looking at the timeline that's been presented to me, and when we're receiving this, and just have those concerns that I'm articulating to you now. So hopefully we'll get there from henceforth, and we can get this thing done the right way with all people being properly considered.
Yeah, I hope so. And like you, I wish I had started this back in May or June when I first got here, and it would have been nice if I had.
Thank you, Chair.
So a couple, I want to make one point is, this is going to go like this for quite a while, but the point I want to make is, as you folks are sitting at the end of the table there, I appreciate the way you're dealing with the position that, in my view, we as a task force have kind of put you in, right? What 3/4 of the states have said is, we're not going to go through all this. We're just going to hire a managed care company, fully capitated risk, outsource all of the difficulties and challenges of balancing all of these things, and pay someone to take care of it and give us our money that we need to save. We didn't do that. Right? I wanted to do it, right? So I was told, look, what we're going to do instead is we're going to agree to the number, and then our DHS folks are going to be able to lead us to a methodology for implementing it. And I've oversimplified what I was told by many people. Of course, whenever you do that, and you say incorporated in what we're doing is $835 million of bending the cost curve, that is going to be a very prickly exercise. And so I appreciate the work effort that we're all going to have to go through to get there, and we realize that right now the burden is on you because you've come up and said, this is managed care, this is a fee-for-service model which does not include the kind of risk that's going to be necessary. How can we come up with some kind of a hybrid? Is this or not? I don't know, but I appreciate the effort that you've put in to get that. So here's how we're going to handle the rest of the day. We're going to go for 20 more minutes, and anyone that has questions will be allowed to ask them. Then we're going to eat lunch, and we're going to come back at 1 o'clock, and we're going to have these folks back at the end of the table at 1 o'clock, or representatives, and we will answer questions until we're done. And then if we get to 5 o'clock and we haven't answered all the questions, we're going to call it a day. We're going to move everything else on the agenda to another day, and we'll go from there. But we will spend the time asking and answering questions until we're done. And if there are still more at 5 o'clock when we finish, we will start the next meeting with whatever questions are left. So we're going to go for another 20 minutes, and then at 11:30, we're going to break for lunch until 1 o'clock. Senator Ingram, you're recognized.
I thought we were going to go to 5 o'clock getting those instructions there. Thank you, Chairman. I appreciate it.
You got me again, Senator.
A couple of things. John, something that would be very helpful to this group is let's do compare and contrast to these three plans, this newest plan, as do not wait till we get the cake baked, as Representative Link had mentioned. As we go step by step, let's do comparison and contrast against the full managed care model and the Diamond Plan. Second, we've all talked about wanting to community-based. Now, within the last 2 years, we turned down going the CFCO model that we're talking about here now. And I think it was based primarily, the opposition was based on entitlements. Did we not ask for some type of waiver regarding language that dealt with entitlements? And I would like, what is the status of that? Anybody?
Hold on, let me see. Does anyone from DHS know the answer?
I would like just an update when they can, and I might be wrong that we didn't submit anything, but we are going to run down a road here that we've been down before because CFCO was going to be community-based. It was going to make economic sense, greater economic sense for the state. There was a savings of about 6% there that we chose not to do. So I just would like to know the status of where we are on that. And then the last thing is I think that early on, if we are looking at a regional model, there has been some concerns regarding, like Dennis Developmental that is through UAMS is my understanding, set up to be regional to do the testing, and there has been some concern expressed that it didn't stay community-based, that they basically set up testing and it was a referral back to Little Rock for UAMS, which defeats the purpose of keeping people in their community. As I remember, there was testimony early on saying that there was just a short backlog of people that needed testing, but when we talk to people in our areas, we're hearing that there are months and months of backlog. So as you take in and go down this regional concept, there are some things that have been done before, and I think you need to really take a close look to see how successful they have been. John, you started to say something, and I was on a roll there.
I'm writing your questions down. I want to make sure, clarify. A while back, before Director Gillespie was here.
Yes.
We had talked about.
In the dark ages, as we refer to it.
Well, we had talked about the CFCO entitlement, and then that the department did have an opportunity under a global waiver to go to CMS and ask them if they would be within the guise of a complete waiver, consolidated all your waivers, to be able to get the 6% enhanced funding, to be able to meet a negotiated spending cap. And we talked about Rhode Island, and we talked about how I had done some work there. I think that eventually, and Dennis is here, and we had discussions with Dennis, happened to be the director when we were talking about that whole concept way back. He had indicated the other day that there will be some waiver discussions down the road about potential consolidation. There could, again, and I don't know, and I'll ask Director Gillespie to comment, but I want to make sure that if that's what you're referring to.
Yes.
Because that was a discussion a while back, and I don't know what the department has done, but I do know if they've asked CMS for any type of enhancement with the conditions. I don't think they have. But I do know that there might be some discussions down the road, and I would be looking out for that based on your interests as well.
Senator, a couple of things. One, and the way you, the language that you used suggests to me that I have not been clear enough that this is not consolidating the services, it's coordinating the services. And this is not where people end up going to a physical place, that everybody is going to be herded into a handful of physical places. If I've given that impression, please let me correct that now. This is about coordinating the care. Arkansas clearly is a very rural state. Many people living in different parts of the states don't have access to specialists, especially the populations that we are talking about that they need. So this is coordinating the care. It is not consolidating the care, if that helps. The second part of the second part of your question on the option that was available, and again, I don't know what Arkansas has looked at or what they considered and or has not done, but that option required states to get the enhanced match rate, which A, is only temporary, and B, required states to be statewide immediately. I don't think Arkansas is in the position to be statewide, and a number of states, most states, in fact, have not gone that route because they could not afford to go statewide.
Thank you. Thank you, Mr. Chair.
Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. Two lines of thought. First of all, regarding the meeting, if you haven't figured out by now, the honeymoon's over. But I don't want a divorce, so I want to keep on the working relationship. But moving forward and adding some other things that have happened in some other committee meetings, like finding out reports from June and us, stumbling into them, I think that speaks to the trust factor moving forward. The question I have about the meetings moving forward, when I look at the handout, you've got a series of working sessions that are going to be happening between now and the 28th. Could you speak about what the format of those meetings are going to be and how you're going to have input from, the legislative branch and from the other providers that are wanting to come in DHS? Because, we're going to have a long meeting today, and I could see that those are going to be long meetings on top of it. So could you speak to that for just a second, please?
Representative Hammer, I've reached out to leadership of the House and Senate and we'll say advised them, and I've talked with the governor's office as well. I expect there'll be some sort of appointment maybe for legislators to visit, not visit, to be at those meetings on a professional capacity. Of course, they're meetings. Anybody can go that can go. But we're hoping that the leadership of the House and Senate is going to make some appointments soon, probably this week, for people, for legislators at those meetings.
Okay, and just one or two quick points on it. Were there any legislators that were in the meeting that this was born out of? Were there
No,
any
sir.
legislators in the room?
No,
Okay.
sir.
And is it not fair to say that from time to time as a department, you probably have to meet with providers to talk through various issues, and in your planning sessions for anything and everything that you bring for the legislative branch, is it not fair to say that you have meetings?
Yes, sir.
Okay. And you don't invite everybody to those meetings, do you?
No, sir.
Okay, so really, this is nothing out of the norm when you look at the history. It's just, it's a more emotional, volatile subject matter because, you know, we're coming down to the wire, the pressure's building and everything else. So I did want to get that out there, that, yeah, you had a meeting, you had it with some providers, but really, we all have meetings with providers and everybody, and not everybody gets invited to the meeting, so I understand that. To this plan, let me say this, and ask about the plan specifically. How does it fold in with the behavioral health transformation and the July 17th date that is out there? And how is this plan going to change anything and the commitments that we have already verbally made to providers and to everybody else?
I can start that, and if you want to add to it. This is, if we go down this route of having this hybrid model, then this is the way that the provider, the behavioral health transformation and the DD transformations will be implemented in Arkansas. So if this works out, our hope would be that we are able to certify some entities to be these new APCOs, RECOs, and that as we move into July and begin the independent assessments, and individuals come into this Tier 2 and Tier 3, they would be referred into those structures. And that's how we would implement, therefore, the task force's recommendations. So they go together. You make the rules changes, and those rules changes create this ability for more services to be provided to those who are not in need of intensive services, and then those who are in need of intensive services through that independent assessment then are referred into this new structure. Lots of details to be worked out about how that works, but they go hand in hand.
Okay, and all those details that you just mentioned, a lot of that's going to be aired out in the subsequent meetings that are to follow, so.
Aired out and figured out.
Right, and I view this as a iron sharpening iron exercise, that to get to the sword that we need to do, the precision operation we've got to do, this is all part of that healthy process. Next question.
Can I just add to Representative Hammer, if it's okay?
Sure.
Because this is important to the task force, and I know Senator Chesterfield, Representative Murdoch, we've been out in the communities. There's a lot of uncoordinated care out there for people that need it. We've talked about from day one that this state has got to adopt a care coordination model. Diamond Care was one of them, through an administrative service entity. There was managed care as another one. At some point, you have to get away from the fee-for-service model you have today to organize that care. So however this all works out, Representative Hammer's question is really important, because in the savings that the governor wants, that you all want, there's a section in the behavioral health, I think they factored $21 million of cost just on care coordination alone. We said at the last meeting, it has yet to be defined. We didn't know about this at the time, but we've kept saying it's just not defined yet. We're coming down to end of December. We've got to deliver a report for you. We have got to figure out a way to define at least the first initial steps of what that care coordination model is going to be. And so I think that this is probably a good opportunity to start having those discussions, but to have involvement of the task force as well, because care coordination is one of your central points, just like independent assessment. And that involves the community. But there has to be a care coordination model before you leave in December, in our opinion, that you all support. At least it would be really good to get on the same page.
Okay, a couple quick ones, Madam Chair, Mr. Chair. With the increased risk that we've heard mentioned, and let me fold two in one, is this approach going to stack the deck as far as hospitals or inpatient providers having greater leverage over independent, smaller providers that may not have the ability, to absorb that risk that was mentioned about, number one? But also with that, if with the increase of risk, is there also an increase of profitability for all providers, whether they're the hospitals
or whether they're the smaller providers, that if they do their business and do it right and do it to the best interest of the patient, their profitability will also increase, which offsets the increase of risk. Is that a perception that's correct according to what I'm seeing here?
I would agree with that characterization, and again, I think so often our focus, when we talk about risk, is managing money, and I keep coming back to managing care, coordinating care, and providing the sufficient incentives. We've talked about, I mentioned briefly, an incentive pool, again, rewarding those individual providers for providing those services in the community so individuals are not ending up in the emergency room or needing a hospital admission. And again, to emphasize your point, and Director Gillespie's point, the behavioral health changes that are already in process, these go along with that. But I would also point out, those are solely within that service group. These savings are coming from avoiding unnecessary trips to the emergency room. They're from avoiding inpatient hospital stays. They are from shortening length of stays in the hospitals. So, as I said in other remarks, the use of primary care should go up. The use of community-based services should go up. And it's those gaps in services is as to why people are ending up in the emergency room and needing an institutional level of care.
Was that not part of the goal and objective of the patient-centered medical homes, though, that patient care coordination would occur under the patient-centered medical home model so that we would actually address this issue and reduce it? And why are we having to deal with it in this method if that model, and are you saying that model is not working?
I'm not saying it's not working. I'm saying we would build upon that and the person-centered medical homes would continue. As I said in my remarks, we're not here to displace or replace. Those things are working, but I think that they will work much better.
Okay, and then the last question is this, and maybe this is for John with the chair's permission. I'd kind of like to know, because this seems to be, as mentioned, a hybrid model where you've actually taken bits and pieces of everything that's been said, probably some of them in private meetings, things that have been aired out in the committee, just from everywhere, and tried to mix it together, adding a couple new pieces that are just coming out today. So I guess what I'd like to ask with the chair's permission is if John could, and his company could, what pieces are new versus the pieces that are pulled from other ideas that we have heard in here? Can you give a comparison sheet just to specifically pinpoint in simple matter where I can get my mind around it? What are the 2 or 3 different things, or 5 or 6 different things other than what was already floating around out there anyway?
Yeah, I think,
Yeah,
as you
and
get ready to answer that, John, what I would just say, I think Representative Hammer, we're going to want a more in-depth kind of
That's fine.
Stevens Group assessment, which would include those things. But John, you can answer however you'd
Yeah,
like.
well, that's what I was going to say. What I thought would be best is one of the questions that came out, I think it was Senator Ingram, wants an approach of what's the difference between Diamond Care, managed capitated full risk, and this hybrid model. And it's a combination of both. It's a little different. There's a few differences. But I think what I want to do for you all is have our team work with them first, because I don't want to say anything until we really get to the point with what it is, because there are things where we have a lot of questions. We just saw this. They briefed us on Friday. I had my team on the line. I have people I trust and respect who have had roles of leadership, and they've already sent me questions, detailed questions. I'm starting to put a list of questions together. I want to make sure that we're involved in each of these work sessions, if it's okay with the chair and the task force, so that we can at least, we feel we have a good idea of what, from your preliminary recommendations of what you're thinking, and we have a pretty good idea of what we're going to be able to present to you, and then you make the ultimate decisions. But, I mean, we can't do their work. We're only in a monitoring role on your behalf. So we just want to make sure that's fleshed out, what your intentions are, and we will do whatever this task force desires.
Mr.
And
Chair,
if I could just add just a note on that. We are thrilled that they are developing questions, because the questions are a lot of what we have to design. So even though they're working for y'all in a monitoring capacity, developing the questions, it really helps the work of design, because it clarifies these are a lot of the issues still to be worked through. So I just want to reemphasize where we are in the process.
If I just may, I want to make sure that this full task force understands, you know, we work for you. And Jill there is the person who I contact, and she contacts the chairs, just so you know the process. So what I want to make sure is we have full direction from you as to how we proceed, because there is, we do work for you. And so anything that we share with the department, before we share with the department, we make sure we share with you first. And so that's always been a good model, and I want to make sure that that model is the one going forward. And again, you know, my team's here, and we're ready to do whatever it needs to take for this state to fulfill our contract obligations with good value, the way we have done so far.
Mr. Chair, may I finish? We'll comment. Again, I want to commend you for, you know, for bringing forth the idea. Maybe it stumbled out of the gate, but I think we can move past that, and I appreciate, you know, bringing the iron sharpening the iron moment. I do have one question, though. As far as the funds, where did you get the money, and which contract services did you take the funds in order to pay for the folks that you used to develop and bring this forward, or can you give me an education on that?
We did not use state money. It was a group of private providers that put together the money and paid for the consultant.
So it was private providers that initiated this? From in-state or out-of-state?
In-state, it paid for the design work to be done by HMA. At our request, we didn't pick the consultant, but so I'm trying to be very transparent about this. I have wondered since last spring when I got here whether a risk-based provider organization model might be a good model for Arkansas. In having discussions with some providers in late July or August, I can go back and look. I said it was a shame we never had a chance to look at this, but I do not have a mechanism to get a consultant to do that. This group said, I went before this group then and said, this is something I would like to explore if someone is willing to step forward and hire a consultant to help us do it. But it would have to be really fast to figure out if it's viable, and then it all has to be everybody at the table to figure out whether or not design works. I've tried to be consistent since the beginning, and I really apologize for the concern over it. But it was all paid for by private dollars, not by state dollars.
Little attitude, Mr. Chair, please. Just a little.
We're getting ready to go to lunch soon, Representative Hammer, so if you think it's going to take time, I'd rather put you after lunch, but if it's quick, then just finish up.
The providers that funded this initiative, were they the ones that were in the room, and/or were they representatives of all the providers so that all the providers' interests were considered when the framework of this began to be put together?
If you mean all the providers in the state, no, sir. If you are asking if they had representatives in the room at some of the meetings, yes.
I'll stop there, and then we'll see where we go after lunch, Mr. Chair. Thank you.
Okay, so what we're going to do now is we're going to break for lunch. We're going to come back at 1 o'clock. I'm going to read off the names I currently have on the list. This is the order we'll pick up with after lunch, and then obviously more people can buzz in. Senator Ervin, Senator Raypert, Representative Boyd. Those are the three I still have, and we'll see everybody back at 1. Yeah, she just took herself. Okay, all right, so you're on there too, Senator.